I will be talking on the role of muscles in neck pain. So, having said that, the broad outline of my talk will be a little bit on the anatomy of muscles involved in leg pain, the muscles involved in radiculopathy, the muscles involved in osteoarthritis of the knee, and a few images of dry needling, most of which I got it from Ashirvad. Janvi had sent it to me. So, having said that, I know that all of you all did the cadaver workshop yesterday. So, you all are all quite familiar with the muscles of the body, having gone through the workshop. But just to recapitulate, I would just like to once again enumerate the muscles of the thigh and the leg, okay, because that is relevant to my talk. So, talking of the muscles of the thigh, so we have in the thigh three compartments, as you are all aware. The posterior compartment, which comprises the the biceps femoris, which has the long head and the short head, the semitendinosus, the semimembranosus. So we know that the biceps have two origins, and they have even a dual supply, nerve supply. The adductor part being supplied by the obturator, and the hamstring part being supplied by the tibial division of the sciatic. They also have insertion is also separately, because you have uh, the one that is arising from the bicep femoris, which arises from the adductor part, is arising from the around the pubic area, the pubic symphysis area, and the hamstring part, which arising from the ischium tubercle. So the pubic part or the adductor part is getting inserted into the femur itself on the linea aspera, responsible for the adduction of the leg. The hamstring part is getting attached to the adductor tubercle in the tibia. Okay, so I'm sorry, adductor tubercle of the fibula. No, sorry. Can you just correct me? The insertion of I mean, they have a common insertion, right? Uh, Anyone would like to correct me? The origins are separate, but the insertion is common of the adductors, right? Because the whole of the biceps is getting inserted into the fibula, right? Now, coming to the semitendinosus and the semimembranosus, they are also part of the hamstrings. The semitendinosus is more superficial, and the semimembranosus is a little deeper, and both of them are getting inserted into the tibia. And the semitendinosus, along with the sartorius and the gracilis, form part of the pes ansoline. So, in fact, the semimembranosus forms the medial border of the popliteal fossa and of the upper part of the popliteal fossa, and the biceps femoris forms the lateral border. Now, coming to the next compartment, which is a medial compartment, is the adductors. The adductor also has basically five muscles, of which the ones of importance to us are the adductor magnus, which again has an adductor, and I got a little confused with the biceps femoris. I'm sorry. This is the adductor magnus, which has the adductor and the hamstring component. I'm sorry about the bicep femoris. Okay, that's a little mistake on my part. It's an adductor magnus, which has an adductor and the hamstring part. The hamstring is innervated by the tibial division of the sciatic nerve, and the adductor part by the obturator nerve. The other thing, the whole of the hamstrings is innervated by the sciatic. Now, so then we have also the adductor longus, adductor brevis, the gracilis, and the pectinis. So these form the medial compartment. And the anterior compartment is the sartorius, which is, of course, the longest muscle in the body. And then we have the quadriceps femoris, which is comprised of four muscles: the vastus lateralis, vastus intermedius, vastus medialis, and rectus femoris. Now, if you look at the cross section, so we need to know the cross section. This is a cross section taken at the mid portion of the thigh. It's important to know the cross section because although you have ultrasound to guide your needles, but if you people like me who are not using ultrasound, we know the trajectory of our needles. For example, here we are going to needle the vastus lateralis. This is a lateral part, and this is a medial part. You're going to needle the vastus lateralis. You can also needle the vastus intermedius. So that's how you know the trajectory, by knowing the cross section of the particular, that is in case of thigh. And then this is a rectus femoris, the vastus medialis. So, and the sartorius. So they all form the anterior compartment of the thigh. And then you have the medial compartment, which is comprising of the adductor magnus and the gracilis, right? And of course, the adductor longus. And then you have the posterior compartment, which is comprising of the biceps femoris, the semitendinosus, semimembranosus, forms the posterior compartment. So this is a cross section of the thigh. Now, if you look at the cross section of the leg, then you have again an anterior compartment, which is made up of the tibialis anterior, the extensor digitorum longus, and the extensor, the flexor, the extensor hallucis longus. I don't know whether it is there. And then you have the lateral compartment, which is made up of the peroneus longus and the peroneus brevis. And posterior compartment, you have the superficial and the deep layers. The superficial layer is the gastrocnemius, the medial head, and the lateral head. Then you have the soleus. This forms the superficial compartment. And the deep compartment comprises of the tibialis anterior, the flexor digitorum longus, the flexor hallucis longus. Because the popliteus is not shown. So now if you look at the video in which you can go through the muscles one by one, here you have the adductors, the hip muscles. That's very important in osteoarthritis of the knee. So this is the gluteus medius. I'll talk about that a little later. And then this is the piriformis. And then below that is the superior gemellus, the inferior gemellus, the obturator internus, and the quadratus femoris. Okay. So these are the muscles of the hip. And here you have the quadratus femoris and the sciatic nerve, which is lying on the quadratus. Now we move on to the muscles of the thigh. So here we have the biceps femoris, which is the long head. And then you have the semitendinosus, and deeper to that is a semimembranosus. And this is a biceps, again, the femoris long head. And this is a semimembranosus. Then we have the adductor magnus. You can see the insertion of the adductor magnus, 2 insertions. Then the vastus lateralis. This is a rectus femoris. Biceps femoris short head, sorry. And now we move on. Yeah.
Can you go back a slide?
This one?
Semimembranosus and together. It's nice to see for everybody.
Yeah.
You know, the view of the from the back. 2 steps before, I think. Yeah.
I'm just starting this part again. The biceps femoris, the semitendinosus. This is a biceps femoris long head. Again, semitendinosus, and this is a semimembranosus. This is what you want to see? Lakshmi?
Yes, I want, but I wanted people to the adductor vis-a-vis the femur and membranosus. We see this very ultrasound. So it's get oriented to this.
Voice is breaking, Lakshmi.
I uh, what I'm saying is, एक minute, just a second. Please. I'll mute. Yeah. What I meant, Mary, is that when we are doing ultrasound guided needling, we see the orientation of adductor magnus with the biceps femoris as well as the semimembranosus tendinosus. This slide is showing that.
Okay.
So I wanted them to appreciate exactly how these muscles are oriented.
Okay.
Sorry, I'm late and I'm butting in.
No problem. You're most welcome to butt in, Lakshmi. You're most welcome to butt in, I said.
Yeah. Thank you.
Okay, can I proceed?
Yeah, please.
Okay. So now this is again the vastus lateralis, and this is the rectus femoris. The biceps femoris. And then now you have the muscles of the calf. We have the two heads of the gastrocnemius, lateral head and the medial head. And this is the gastrocnemius again, lateral head. This is soleus muscle, okay? This forms a superficial compartment, the superficial posterior compartment. So this is a flexor digitorum longus of the foot, the flexor hallucis longus, and the fibularis longus. And then this is the extensor digitorum longus, and you have the fibularis brevis. Okay. So this is a little video about the muscles of the thigh and the gluteal region, thigh and the leg. So now coming to radiculopathy of the leg. We all know that whenever there is a disc prolapse, there is an impingement of the particular nerve root. So in this case, it is L4-5, and this is the L5 root, the traversing root that has got impinged. So whenever there's an impingement, there is a mechanical component formed by the prolapsed disc per se, and there is an inflammatory component. The inflammatory component is because the disc material, that is a nucleus pulposus, has a substance called phospholipase A. And that, when it is released, it elicits an inflammatory reaction. So there is a lot of edema also. So it is a mechanical and the inflammatory component that is now in this particular thing is impinging on the nerve root. And that is a rationale of giving steroids because it is an anti-inflammatory. You cannot do anything about the mechanical component, but you can treat the inflammatory by giving a steroid. Now, besides that, there is also a muscular component. And that is because whenever there's a pain, the paraspinal muscle, particularly the deep muscles, like the multifidus and the semispinalis, they go into a spasm. So that spasm is also causing an impingement. So basically, there's a mechanical component, inflammatory component, and a muscular component. This was not recognized by most people because I used to work in a neurosurgery setup where they would only treat the mechanical component, and if they felt that a steroid is indicated, they will ask me to give the steroid. Nobody ever thought of addressing muscular part of the problem. And now we are doing so many patients with prolapsed intervertebral disc where they are responding just by treating this muscular component. Even without giving steroid or without getting a surgery done, they are getting good relief of pain and they are able to move about and go on with their activities of daily. So the muscles that we were talking about the paraspinal muscles, but the muscles that are involved in radicular pain, particularly in this case, it's the L5, we need to address the hamstrings, the calf, and the peroneal muscles because that is the L5 distribution. So we need to address this, and by needling not just the back, but we also need to address this part of the sciatica problem. Only then they will get good relief of it. So this is dry needling of the back of the thigh. Okay, here we are needling. The needles are in the hamstrings, the semimembranosus, semitendinosus, and many cases even the vasti are needled, vasti lateralis and vastus. Okay. And this is another one This is the medial and this is the lateral part. And here we can see how the semi-membranosus, semi-tendinosus, and the bicep femorals are needled. Case of that. And then moving on, we need to also needle the calf muscles. So here we have the gastrocnemius, the medial part and the lateral part. And we can also needle the peroneus longus and the peroneus brevis. That's only that completes the needling for radicular routine. Again, another view of the calf. You can see the peroneus longus and the peroneus brevis along with the gastrocnemius. So when you do dry needling for radiculopathy, along with the muscles of the back, we also need to address the muscles of the leg to relieve the pain in a satisfactory. Now coming to osteoarthritis of the knee. The muscles involved in osteoarthritis, if you look at literature, they always talk of quadriceps and they talk of the hip abductors and hamstrings, but very few people think of calf muscles and sartorius. Because the physiotherapists and the chiropractic people, they always focus on the quadriceps. But after the experience in Ashirvad, this is the conclusion that we need to address the quadriceps, the sartorius, the hamstrings, the hip abductors, as well as the calf muscles, both the superficial and the knee. So these are some diagrams in which you please see the red arrows. So this is a sartorius muscle. This is a semitendinosus muscle. This is a vastus lateralis, vastus intermedius. Vastus intermedius is actually wrapped around the femur and it is deeper to the vastus lateralis. And of course, we have the vastus medialis. So these are the muscles that need to be needled. This is the anterior view. The lateral view, you can again see the quadriceps muscle. And here, this is the insertion of the quadriceps. And then you have the pes anserine. The pes anserine is inserted onto the medial aspect of the tibia. And from anteriorly, it is the sartorius, the gracilis, and the semitendinosus. Then we have the semitendinosus muscle and also the sartorius muscles. And here we have the medial head of the gastrocnemius. This is the lateral view. Sorry, this is a medial view. I'm sorry. And then we have the posterior view for the muscles of the leg. Here you can see the semitendinosus, semimembranosus. We have the gracilis, the sartorius. This is forming the pes anserine here. We have the biceps femoris on the lateral aspect. And then we have the gastrocnemius lateral head and the medial. This is how you needle from the posterior. So here we have the dry needling of the quadriceps. By needling the quadriceps, the vastus lateralis, we can also simultaneously put a needle into the vastus intermedius because that's lying deeper around the femur. Here we have the needling of the posterior aspect of the thigh for osteoarthritis. Here the needles are lying in the biceps femoris, vastus lateralis, vastus intermedius, and the semitendinosus and the semimembranosus. This is another picture showing the same thing. Yeah, the needles are in the semimembranous tendinosus, biceps femoris, vastus lateralis. Now, the abductors of the hip also need to be needled in cases of osteoarthritis. Because when you strengthen the hip abductors, it decreases the hip adduction, it decreases the medial compartment moving on the knee, and decreases pain and disease progression. So the gluteus medius is a very important muscle that needs to be needled in case of osteoarthritis. And the other abductors of the knee are the vastus lateralis, the tensor fascia lata, and the gluteus minimus. So if you look at the algorithm for back needling in an averagely built patient, for the buttocks, particularly the gluteus medius minimus and the piriformis, we need to use about 100 to 120 mm needles. For the back of the thigh, which include the adductors, the bicep femoris, the semimembranosus, semitendinosus, vastus lateralis, we can use between 100 to 120 mm. And for the leg muscles, the gastrocnemius, soleus, peroneus, longus, brevis, and the tibialis anterior and posterior. You can use it. That's my presentation. Thank you.